The goal of Allergy and Asthma Network's webinar series is to share guidelines-based information and resources with you that are relevant to your life and your practice. This series is a part of how we live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. Good afternoon. This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and welcome to our 2018 webinar series titled Advances in Allergy and Asthma. Our webinars are also brought to you by the American College of Allergy, Asthma, and Immunology. This webinar is titled When Histamine Meets the Skin, the Trials and Tribulations of Chronic Idiopathic Urticaria, and we're pleased today to be joined by Dr. David Kahn. Dr. David Kahn is a professor of medicine and pediatrics at the University of Texas Southwestern Medical Center in Dallas. He is the program director for the Allergy and Immunology Fellowship Program at Southwestern. Dr. Kahn is a past president of the Texas Allergy, Asthma, and Immunology Society and a current member of the board of directors of the Academy of Allergy, Asthma, and Immunology. He's also a member of the Joint Task Force on Practice Parameters for Allergy and Immunology. He received his medical degree from the University of Illinois in Chicago, and after completing internal medicine residency at the Good Samaritan Medical Center in Phoenix, Arizona, he went on to fellowship training in allergy and immunology at the Mayo Clinic. His research interests include drug allergy, therapies for refractory chronic urticaria, rush immunotherapy, and the interaction of depression and asthma. He has authored over 120 publications. He's obviously very busy. I'm glad he had time to join us today. And Dr. Kahn, we do thank you very much for joining us today. We're eager to know more on this subject.
Well, thank you so much for the invitation. And it's a pleasure to be able to spend the next few minutes talking about a disease that I think is equally frustrating for patients as well as it is for providers, and that is chronic urticaria. So on this first slide, you'll see where I'm from. That's UT Southwestern. These are two of our new shiny hospitals. On the left is our Clements University Hospital. On the right, that large thing that looks like a sewing machine is our brand new county hospital, Parkland. So these are my disclosures, and one, I think, important thing to discuss is that for treatment of urticaria, the only medications that are approved are antihistamines and Omalizumab, and everything else is actually considered off-label. So there's several things that I hope that you'll get out of this presentation. First is an understanding of how frequent chronic urticaria is. We'll talk a little bit about what we know and really what we don't know about the pathophysiology, how it can present, how we diagnose it. We'll talk about prognosis and ultimately management. There are some recent guidelines that have been published, and I'd like to share those with you. And then we'll talk about what tests one should consider when evaluating patients with chronic urticaria, and then management strategies to best deal with successful management of these patients. So let's first start talking about what is urticaria. And urticaria are really transient wheals that are associated with redness and itching. They can range from just a few millimeters in size up to several inches. And typically these wheals are transient. They only last for hours and typically less than a day. And when they leave, you shouldn't see any changes at all. The skin should look completely normal, and that is typical urticaria. And here's some pictures that show different morphology of these lesions. You can see that they're typically red, have irregular borders, sometimes a little paleness in the center of them, and again can range in size from relatively small ones to larger ones, which is seen in the left bottom panel. Now, another condition that commonly comes up with urticaria is angioedema. And the way to think of this is when urticaria is occurring deeper within the tissue, it causes more swelling. And that's what angioedema is. It's swelling that's associated with this kind of phenomena. Many patients, in fact, probably most people who have chronic urticaria at some point will have angioedema. This typically presents in an asymmetric fashion. So, for example, one lip may swell up, one side of the lip may swell and then continue on the other side. It is less itchy than is urticaria and tends to last a little bit longer, often on the order of days. Here are some photos of patients with angioedema. Angioedema most commonly affects the lips and the eyelids, but it can affect many areas of the body. And in this slide on the right, you can see swelling of the arm and hand. Now, in terms of how we classify urticaria, there's an arbitrary classification scheme of acute versus chronic. And acute urticaria means that it lasts less than 6 weeks, and chronic more than 6 weeks. This is an important distinction because there are big differences between acute and chronic urticaria. With acute urticaria, we oftentimes think of this as an allergic problem. So this could be due to a food allergy or medication allergy or stinging insect allergy. And frankly, it's much more common. Up to 20% of the population may be affected by acute urticaria. In contrast, chronic urticaria is less common. In the majority of cases, we are unable to identify a cause. And this is known as chronic idiopathic urticaria, especially in the US, but internationally, there's been a change in nomenclature to chronic spontaneous urticaria, but we're really talking about the same thing. Another form of chronic urticaria that is probably the next most common is when there's some stimuli, oftentimes a physical factor that can trigger urticaria, and this is referred to as physical urticaria, oftentimes in the US, and elsewhere the new nomenclature is inducible urticaria. Now, how common is it? Unfortunately, we don't have great epidemiologic data in the US, but studies on acute urticaria suggest that about 20% of the population may have this. And this was true in 1969 and then looked at in England. And then in 2004, the same prevalence was found in Spain. In terms of chronic urticaria, the prevalence is much less, about 0.6% for those that have active disease. And again, this has not been as carefully studied in the US. Now, there are some characteristics of patients who have chronic urticaria. This is much more common in women than men and is more frequent in middle age, with the typical age of onset in the 40s. And the big question is it becoming more common? And we actually don't know, but there's a perception, certainly amongst allergists in the US, that there is an increase in patients that we're seeing for chronic urticaria. Now, why do people get urticaria? Well, one thing that's going on is the mast cell is being activated. You know, the mast cell has a number of different receptors on it and can be triggered through a variety of mechanisms, through allergen, through other medications. Sometimes viruses or bacteria can trigger mast cells, and other antibodies can directly stimulate mast cells. And when mast cells are stimulated, they degranulate and release a host of mediators that can then result in urticarial or angioedema lesions. And this is a list of some of the mediators that have been suggested to play a role in chronic urticaria. Histamine is highlighted because we think this is one of the more important mediators. And when you inject histamine into the skin, you indeed do get a hive lesion. But we also see patients who, despite taking massive quantities of antihistamines, clearly blocking the effects of histamine, that they still have hives. So it may not be the sole mediator involved in some patients with chronic urticaria. Now, what drives and what starts chronic urticaria, we still don't really understand. There are a number of different theories out there, but they all still remain theories. One that has been around since the 1980s is what's referred to as the autoimmune theory. And this is based on the fact that about a third of patients may have identifiable autoantibodies. And these autoantibodies are against the high affinity IgE receptor on mast cells or basophils, and this can then thought to be triggering the mast cell to release histamine. There are some problems associated with this theory. One is, are these really pathogenic antibodies? And importantly, do patients who have these antibodies, is this a unique subset of patients, or do they behave much like other patients? Unfortunately, the presence of these antibodies doesn't really seem to affect treatment decisions. Another theory relates to differences in basophil responsiveness. This is all done in vitro in the laboratory, where you can find patients with chronic urticaria. Some of their basophil, or some patients may have basophils that respond very nicely to anti-IgE and others that don't. And again, how does this relate to what's going on is still being discovered. So we still have a lot to learn about what drives this disease. There have been a number of different factors that have been looked at in terms of correlations with chronic urticaria. And this slide lists some of these. What you can see is there's a lot of different things. Some of this relates to the autoantibodies. Some relates to other inflammatory markers. And what we're starting to recognize is that chronic urticaria is indeed a disease of inflammation and may have some systemic effects, if you will. This is a recent paper that looked at an inflammatory marker, C-reactive protein, and found indeed it was elevated in patients with chronic urticaria in about a third of cases. They also found that those that had higher elevations in the C-reactive protein, this marker of systemic inflammation, it seemed to correlate with their urticaria activity scores, which is shown in these graphs below. Now, if you have a high CRP, does that help in terms of predicting whether you're going to respond to antihistamines or not? And this is from the same study looking at the positive predictive value. And what you see is really, it's not much better than a flip of the coin. So I don't think it's really particularly predictive in terms of determining whether one is going to respond or not respond to antihistamines. Well, let's talk a little bit about the natural history of this disease, and also importantly, how this disease affects patients' quality of life. So the natural history does differ based on the type of urticaria one has, and also what clinic you're going to. So this is a study looking at a dermatology clinic, so seeing a little bit more severe end of the spectrum of patients. And what they were interested in is looking at how many patients were free of hives after a year. And when they looked at the idiopathic patients, about half of them had undergone remission and had no longer were having hives. That meant half were still having hives. When you go down to the bottom and look at physical urticarias, only 16% were free of hives. So the vast majority after a year were continuing to have hives. And this has been shown in other studies in that physical urticarias do last longer than idiopathic urticaria. Now this next slide is from a different referral center. This is referred to as a supra-regional referral center. So they took on really the toughest cases of urticaria. And here, more than half of their patients after 10 years were still having urticaria. And again, those with cold urticaria or other physical urticarias had a worse prognosis and longer duration of disease. Now, patients don't die from chronic urticaria. This is not a life-threatening condition, but it certainly impacts their life, mainly because of the itch, but other factors can be a problem as well. And there are a number of different studies looking at quality of life and comparing it to different diseases. But I think one of the more notable ones is this famous study that was looked at taking a health profile questionnaire that had been used in patients who had coronary artery disease and were awaiting coronary artery bypass graft surgery, taking that same survey and applying it to patients with chronic urticaria. And this is the data here. In the blue bars are the patients who have heart disease, and in the red bars are patients with chronic urticaria. And you can see for these different domains of quality of life that patients with chronic urticaria were very similarly affected as just like patients who had bad coronary artery disease. So this is a useful way of communicating with other physicians who are more familiar with coronary artery disease and tend to oftentimes dismiss urticaria as being a benign illness, which it clearly is not. Now, in this same article, they asked patients, what was the worst thing about your chronic urticaria? And many of these patients, in fact, the majority, felt that swelling was the thing that affected them the most. And I would say amongst my patients, that's also a huge thing that really bothers them. Itch is a very troublesome symptom. And then there are a variety of other things, that this was unpredictable, embarrassing, etc. So a number of factors can show how this really causes problems in patients' lives. Now, one way of measuring not only disease activity, but also quality of life is through an urticarial control test. And it's now starting to be recommended in different guidelines that we use some objective way of monitoring patients. And this is a fairly simple 4-question survey that you can use in your patients to score them in terms of how they're doing in regards to their urticaria. Okay, so you have a patient who presents with chronic urticaria. And the question is there something else driving this? And what kind of testing is needed to exclude some other illness? So this is a slide from the Choosing Wisely campaign, which is something from the American Board of Internal Medicine. And this group asks a number of different specialty organizations to say, are there areas that we probably shouldn't be doing something? Where are we doing too much testing? And so this was the first iteration from the American Academy of Allergy. And I want to highlight number 3, which was don't routinely do diagnostic testing in patients with chronic urticaria. And why is that? Well, this comes from the Urticaria Practice Parameters, which is the US guideline for urticaria. And basically, the summary statement in terms of what to do for testing is it gives one 2 options. So first and foremost, you need to take a history and physical examination and a complete review of systems to make sure there isn't something else going on. But many patients will just have the only thing that's going on is their hives. And if that's the case, what can you do in terms of labs? You may choose not to do any testing, and that's certainly appropriate. Or you can do just some limited testing on a routine basis. The emphasis was against doing extensive laboratory testing in every patient that you see with chronic urticaria. And that's because this type of testing does not yield significant findings when you do it in everybody. So routine laboratory testing actually rarely yields clinically significant findings. So this is what the Joint Task Force came up with as a reasonable number of tests that one can consider, such as the CBC, sedimentation rate, CRP, thyroid stimulating hormone, but a small number of relatively inexpensive tests if you want to do this. And the fine print at the bottom, it says the utility of performing the above tests routinely has not been established. And I would argue to the contrary that most studies, when they look at laboratory testing, have not found them to be particularly helpful in coming up with a diagnosis that you'll be missing. Now, there are patients, however, that may have other things in their history or other points that you say, well, you know, this is not typical. And here you can certainly pursue any diagnostic considerations that may be appropriate. And here is this is an incomplete list of other tests that one might consider. But again, this is not for every patient and should be done on a case-by-case basis. Now, I had mentioned that there are new guidelines out there, and this is a statement from the most recent international guidelines, which I'll be talking about a little bit more detail shortly. But these guidelines also recommend very limited tests, such as a CBC with differential and a CRP or sedimentation rate. Now, there are some additional tests that one might consider if one is thinking about these physical or inducible urticarias. And what's shown in the top panels are some of the different testing instruments that one can do. So in panel D, that has its 4 prongs, this is a dermographometer, and in panel A, when you stroke the skin, that's what you elicit if you're concerned about dermographism. Panel E at the top shows a weighted rod, which has been applied in panel B below, and shows an area of redness and hives related to delayed pressure urticaria. There are ways of testing for ultraviolet light, for cold and heat, and these are also depicted in these slides here. So when you have a suspicion for some type of inducible or physical urticaria, there are methods for provoking those reactions and confirming that. All right. Well, we've moved on from testing, and let's talk about management here. And this is a patient that I saw about a year ago who's a 70-year-old who presents with 20 years of episodic hives. And now these hives have gone from being episodic to daily, and oftentimes having frequent angioedema. He can't identify any specific triggers. His prior laboratory workup has been negative. He's currently on fexofenadine, 180 milligrams twice daily, and hydroxyzine, 25 milligrams at bedtime. Not having any side effects, but also not having any benefit. And on examination, he has scattered, blanchable, typical-looking urticaria. And the question is, what do we do now? So I alluded to the urticaria practice parameters, which was updated in 2014. And in this parameters, there was a stepwise approach that was recommended. And after your initial evaluation, the first step is starting with second-generation antihistamine. If that doesn't work, you go on to step 2, which gives you a lot of different options. You may increase the dose of that second-generation antihistamines. You may add on another second-generation antihistamine. You can consider an H2 blocker, a leukotriene antagonist, or maybe a first-generation antihistamine. If none of those things are working, then the recommendation was to add a more potent antihistamine like hydroxyzine or doxepin based on tolerability. And if that didn't work, you went on to some of the alternative agents, such as Omalizumab or cyclosporin or other things after that. Now, the international guidelines, predominantly from Europe, has just been published this month in Allergy. And let's take a look at what their recommendation is. So they also started off with second-generation antihistamines. And if this didn't work, they recommended increasing the dose of the second-generation antihistamine up to 4 times. And if that didn't work, they went straight to using Omalizumab. And if that didn't work, they went on to cyclosporin. So a similar but slightly different algorithm for approach. So if we look at, and this is kind of comparing one guideline versus another. On the left-hand side is the International European guideline, and on the right side is the practice parameter. And you can see step 1 is identical, and step 2 is there are some more options in the US parameters for considering H2 blockers, leukotriene antagonists. Step 3, there's the advancement of older antihistamines. And step 4, I would say, here is Omalizumab, which is recommended in step 3, and also cyclosporin. So it becomes similar after a point. Well, what is the evidence for higher doses of antihistamines? Because this has been recommended in just about all urticaria guidelines. This is from a systematic review and meta-analysis. And interestingly, despite the fact that many guidelines give a high level of recommendation for using high doses of antihistamines, the data only support the fact that, yes, itching gets better, but not necessarily wheel number. And there are problems with the studies that have been performed to date. So this is looking at this meta-analysis. What they found was about 38% responded to standard antihistamines. When you increase the dose, there was a higher response rate. However, there was a lot of differences between the studies, and many of these studies did not have very good quality. So again, if we look at the international guidelines, they do recommend fourfold increase, and they gave one kind of arrow up, which meant decent evidence, but maybe not great, but there was clearly good consensus. And the US practice parameters basically said, yes, we recommend it, but we recognize that the data is conflicting. Now, what about higher than fourfold doses of antihistamines? So this was a recent paper from the Netherlands where they looked at patients who started with typical doses of antihistamines. If that didn't work, they went up to fourfold. And if that didn't work, they usually added on another antihistamine and went up with that. So let's see what happened with this approach. So what you can see is that the licensed dose of antihistamines only worked in about 22% of patients, so not very good. When you went up to fourfold doses, you found more patients that it worked in, but still about half of patients it was insufficient. And then what they did was they added another usually second generation antihistamine, or sometimes another first generation antihistamine. And what they found was you could reduce the need for additional therapy, such as Omalizumab or other things, by about 50%. So this does suggest that more aggressive antihistamines may give us added benefit. And again, this is what is recommended in the US practice parameters in terms of using things like hydroxyzine or dioxepin. These drugs are not the same. And when would I consider using which one? Most of the time, it's based on what the patient has tried before, recognizing that dioxepin can be associated with more weight gain and likely maybe a little bit more sedating. The key with using these medications is to start kind of at lower doses and gradually work up. I like to dose all in the evening because it reduces the daytime somnolence. It doesn't eliminate it, and there are patients who will clearly not tolerate this, but it's a strategy that can be successful in some patients. Now, one concern that has come up with first generation antihistamines is the fact that these do have anticholinergic side effects, and there has been an association of increased dementia with use of anticholinergic agents. And when you look at the data, if 3 years of therapy with hydroxyzine at 75 milligrams a day or just 10 milligrams of dioxepin is kind of the cutoffs for when you're seeing that increased risk. Now, importantly, this is an association and has not been proved as being truly causally related, but patients and insurers are certainly aware of this. So let's go back to our case. Our 70-year-old man with 18 months of daily hives, frequent angioedema. He's currently on higher doses of fexofenadine and a low dose of hydroxyzine. He's not any better. So if we look at what the guidelines say, the international guidelines would say, let's put him on Omalizumab. And the practice parameters would say, well, maybe we can advance his first generation antihistamine as tolerated. And essentially, that's what we did. We increased actually we changed his second generation antihistamine to higher doses of cetirizine, and he gradually increased his hydroxyzine up to 100 milligrams at bedtime. And he went from daily hives to having hives that were less than once a week and what he called nuisance. And it really didn't have any issues with sedation. Subsequently, he's tapered down on both his cetirizine and his hydroxyzine and continues to do well. So I think the take-home point is that I think these other first-generation antihistamines or multiple antihistamines do have a role in patients with chronic urticaria and may avoid the need for other biologics and other alternative agents. Well, let's move on to another case. This is a 50-year-old woman who's had relapses of chronic urticaria. And this is something that definitely can happen, that there are patients who have chronic urticaria, gets treated, goes away, and then comes back again. So in 2006, she had her first episode of chronic urticaria, failed to respond to high doses of second-generation and first-generation antihistamines. And so then she went on to other alternative agents, hydroxychloroquine, and then was treated with dapsone. And she did well with the dapsone and tapered off it after 2 years and had no hives at all for about 5 years. And then her hives came back. She tried the antihistamines again, and because she had responded to dapsone, we said, well, let's put her back on dapsone. But putting her back on dapsone did not help her. So if we go back to the guidelines, in both the international European guidelines as well as the practice parameters, we're looking at likely starting with Omalizumab. So Omalizumab has really revolutionized the treatment of chronic urticaria. And again, it's been the only new therapy that is FDA approved for chronic urticaria. So I do want to spend some time talking about it and some of the things that we've learned over the last few years with Omalizumab and urticaria. So this is an important paper that kind of took the 3 pivotal studies that were used to submit Omalizumab for FDA approval and analyzed it in a slightly different fashion. So one thing is which of the doses is the best dose. There's 2 doses that are approved in the US. That's 150 milligrams or 300 milligrams administered every 4 weeks. And if you look at an outcome of not having any hives at all, that's here what's shown as the UAS7 equals 0. What you see is that the 300 milligram dose was much more likely to accomplish that than the 150 milligram dose. And what I didn't show you is it also works faster. One of the biggest questions that comes up is it's easy to identify some patients who respond to Omalizumab because they may respond within days of their first injection, their hives go away, and you know they're clearly a responder. But other patients, it takes longer. And the question is, at what point do you say enough's enough, this drug is not working? And there's not, I would say, a clear answer on this, but from this study, it suggests that based on the randomized controlled trials, somewhere in the neighborhood of 3 to 4 months or 3 to 4 injections, you would get the maximal effect from Omalizumab versus placebo. Now, even after that, you will see that over time, the response does improve on the blue lines with Omalizumab, but you also see that same degree of response with placebo. We know that chronic urticaria can go away on its own. So the question is this natural history, keeping them on it longer, or is it really the drug having an effect? And so this is still a little bit of an unknown. When do you call it quits? Now, this was a recent study that looked at patients who were treated open label with Omalizumab, 300 milligrams every 4 weeks, and then randomized to either continue it or stop it and see what happens. So this is the first part of the study, looking at open label Omalizumab for 24 weeks. And in the gray bars, what we're looking at is what is considered control of urticaria, a urticaria activity score 7 of less than or equal to 6. In the whitish or lighter color bars are those patients who had no hives at all. And what you see is that over time, there is a little higher rate of response, even from, say, week 16 to week 24, both for control as well as lack of urticaria. Again, this is open label, so we don't know how much is just spontaneous remission or not. But what it does show is that about 70%, 73% of patients at week 24 do have control of their urticaria, but that's not 100%. Now, what happens when you stop it? And this is what they looked at. They randomized some of these patients to continuing the Omalizumab after 24 weeks, and some got placebo. And what this graph is showing is the time to relapse, losing control. And what you see in the top, the solid line, are the Omalizumab group, where there were a few patients that lost control, but for the most part, it remained fairly flat. And as you might guess, those in the placebo had a higher rate of relapse, although again, still, a number of patients continued to do reasonably well on placebo. Now, in those patients who flared so bad that the investigator decided that let's retreat them open label, what you see is that the Omalizumab worked nicely again, and within 12 weeks of treatment, really kind of squashed the urticaria activity score down nicely. Now, how long can one use Omalizumab, and does it continue to work, and what happens over time? So these are studies that are still ongoing. This is a paper from our group that we published our experience, and these were in patients that were treated actually before Omalizumab was actually approved for chronic urticaria, so we were kind of using it off-label. These were a group of fairly refractory patients that had tried lots of different antihistamines, a variety of other alternative therapies, and many of them had frequent need for systemic steroids and some daily systemic steroids. And what we found is that when we tried to taper these patients, most of them had a relapse of their urticaria, and very few were able to do well without it. And again, I would say this is a biased group of more severe refractory patients. Now, in terms of duration of Omalizumab, you can see there was quite a range in it, but I'll point you out to one patient here, number 2, and this was in 2015, had 112 months of therapy. So he's been on Omalizumab now for almost 12 years, or actually more than 12 years, and still needs it. When we try and taper it, his hives come back. Yet when we use it again, it works. So there are some patients that need it for a long period of time, and it can be safe to do so. Now, what about more frequent dosing? The dose is typically every 4 weeks. Can you administer it more frequently than that? There aren't any controlled studies that have looked at this, but there are anecdotes and case series that have been reported that have looked at this effect. A very recent paper in this month's JACI in Practice looked at patients who had this kind of wear-off effect, meaning on 300 milligrams, they did well for the first 2 to 3 weeks, but then had a flare of their hives just before their next injection. And what these authors did, and this is a small sample of patients, but they split their 300 milligram dose into 150 milligrams every 2 weeks and found that that actually worked better. So this is an interesting thought process in terms of how to approach these patients. Can you predict which patients are going to respond to Omalizumab? This was a retrospective study that looked at using a basophil activation test to see if it could determine who responded and who didn't respond. And the basophil activation test is oftentimes a marker for those patients who might be labeled as having autoimmune urticaria. And in fact, the autoimmune patients, based on how you would define it here, were less likely to respond to the Omalizumab than those who did not have this assay. Again, this is a retrospective study, and I think deserves a further investigation. Now, there have been several studies that have been reported within the last year or two looking at IgE levels and do they predict responses to chronic urticaria. And the suggestion is that patients who have low IgE levels may not do as well with Omalizumab. So this is a study looking at patients with baseline IgE levels, and they categorize their response as those that had complete response, partial responders, or no responders. And what you see is that the no responders, their baseline IgE had a mean of about 18 compared to the complete and partial responders who were between 73 and 82. Now, what was interesting was they looked at what happened at week 4. And at week 4, the IgE actually increased quite a bit in those that responded, but not in those that didn't respond. And so these authors said, well, what if we looked at if you had a twofold rise between IgE at baseline and 4 weeks later? And if that happened, the majority of these patients were going to respond to omalizumab. Now, if it didn't happen, there were patients that still responded, but there was a little higher rate of non-response. So is this something that can be used clinically? Well, I would say at this point, while it's suggestive, it certainly is not quite strong enough to indicate that you would or would not treat someone with omalizumab. But I think this is something that we'll have to follow the information over time. So there's some predictive value, but will it really change your management? I think that remains to be seen. Now, omalizumab is indicated primarily for chronic idiopathic or chronic spontaneous urticaria, but there are these urticarias out there, the physical or inducible urticarias, and will it work for those? And this is a review that suggested that for symptomatic dermographism and cold urticaria, that there were enough studies, randomized controlled trials, to suggest that omalizumab can indeed be effective in these patients, and case series and other case reports suggesting that it may be helpful for other forms of physical urticaria as well. Now, I mentioned before that angioedema commonly accompanies patients with chronic urticaria, and what happens with angioedema in patients treated with omalizumab. And this is a study that looked at that. So these were patients who had chronic urticaria and angioedema, and they were interested in what the outcome was. And so here we're looking at placebo in the blue and omalizumab in the red, and what you see is a dramatic reduction in angioedema attacks compared to placebo that looked, and similarly with the urticaria, a nice reduction in urticaria scores as well. So there does appear to be an effect on angioedema as well in patients treated with omalizumab. Now, why does omalizumab work in chronic urticaria? And as you can see from this very busy slide with lots of things on there, the answer is we don't know. So there are a number of different things that happen with omalizumab in patients with chronic urticaria that relate to IgE receptor density, effects on mast cells, effects on degranulation, effects on other downstream effector cells, and which of these is really critical in why omalizumab works in chronic urticaria remains to be seen. So this is still an area of active research. So back to our case, our 50-year-old woman who had a relapse of chronic urticaria and this time did not respond to both antihistamines and dapsone. She was treated with omalizumab every 4 weeks and over 3 months had progressive improvement and then became high-free. After 6 months, her omalizumab was tapered to every 6 weeks and then 8 weeks, and then eventually stopped after about a full year of therapy. She remained high-free off the omalizumab for about 2 years, and then it flared, and now she's back on omalizumab again. So omalizumab, while it has been successful in the majority of patients, doesn't work in everybody. And again, showing this slide from the open label studies that at least 27% of patients will not have a significant improvement on omalizumab. So what can one do? Well, there's a lot of different other alternative agents that have been used. We had mentioned cyclosporin. There are other immunosuppressant agents, tacrolimus, mycophenolate, and other anti-inflammatories. We talked about dapsone, but other things like hydroxychloroquine, sulfasalazine, et cetera, can be used. Studies documenting the evidence or efficacy for these agents are fairly limited, and most of these studies have very small numbers. So the data isn't very robust, but I think both the international as well as the US guidelines do indicate that long-term systemic steroids is not a recommended approach for these patients, and it's probably better to use an alternative agent prior to condemning them to systemic steroids. Now, once you found something that works, how long do you treat? And what we typically do is first try and get them off steroids, then get them off the other medications. I like to keep them calm for at least 3 months and then taper them over the next several months. Some patients may require ongoing therapy for many years, and what you can do is just kind of find the lowest dosage to keep them controlled. So in conclusion, chronic urticaria has a significant impact on the quality of life. Most cases do remain idiopathic. Doing a lot of laboratory tests is not helpful in the absence of a history or physical that drives you that way. Antihistamines work in many patients, and higher doses or multiple agents may be additive. Omalizumab is effective in most of these patients who have antihistamine refractory chronic urticaria, and it can also work for other physical urticarias as well as angioedema. Other alternative agents can be used, but the evidence we recognize is not good. But I still think it's helpful in terms of improving patients' quality of life and is better safety profile than long-term systemic steroids. And I will end with a quote from Voltaire that I think summarizes a lot of sometimes how we feel when we're managing chronic urticaria, and that is, the art of medicine consists in amusing the patient while nature cures the disease. And with that, I will end and be happy to take any questions. Thank you.
Thank you so much, Dr. Khan. Totally appreciate your words today. We do have questions. Our first question is, why do I tend to have breakouts most every evening? If the hives last several days, they are always more inflamed and worse in the evenings.
So that is a great question, and something that we do hear from a lot of patients is that their hives are oftentimes worse in the evening. And I think the short answer is, we don't know why that is, but we do know from a lot of different diseases, including a lot of other allergic diseases, that there are what we call circadian rhythms, biologic rhythms in inflammatory cells that are more active in the evening hours. Sometimes this is thought to relate to your endogenous cortisol levels. So cortisol is a steroid that would be helpful in patients who have hives. Is that the reason? We don't know. Certainly in the evening when people are less busy, they are certainly more aware of their hives, but there are definitely some people who clearly flare in the evening, and we don't know why, but that's not unusual.
Okay, I actually can answer the second question. And the second question is, will we be able to get a copy of the presentation slides? And as a rule, we do not share the presentation slides because they're the intellectual property of our speakers, and our speakers are often using them in different presentations that they do. But we will have this recorded, so if there's something you'd like to go back and look at, you will be able to do that, and you could be able to stop and start the recording so that you could check out a slide that you're interested in. Our next question is, I find allergy testing, usually serologic, rarely yields a cause, but helps patients more rapidly move past the "this must be an allergy" phase, especially if they are refractory to antihistamines. Do you agree or disagree?
So I would certainly agree with the point that doing allergy testing, either through skin testing or serologic testing, doesn't really add any value. And I think this is certainly voiced in both the international and the US guidelines. The other part of the question is, do these kind of tests, even when they're negative, help the patient move forward with other treatment recommendations, or does it help from a reassurance value? And that's a question that really has not been addressed. And this is something that we discussed on the practice parameters, that a number of different physicians were recognized that we do these tests out of reassurance value, thinking that this will help reassure the patient. Personally, I started off with that philosophy that doing laboratory testing would help reassure the patient. I have moved away from that because I found that it really didn't seem to reassure patients. And I think if I spent just a little bit more time explaining the rationale why I'm not doing the testing, that the patients were okay with that. So I don't think we know the answer, and I think part of it is depending on your approach.
Okay, great. Thank you so much. Next question is, can you give Xolair every 8 weeks in a controlled patient?
So as mentioned earlier, the recommended dose for Omalizumab Xolair is every 4 weeks. But we do recognize that there are patients who require it long term, and can you get by with less frequent dosing? And I think you certainly can. My approach, and there is no right approach, and this is something that I think is being, that hopefully will be looked at a little bit more vigorously, is what's the best way to de-escalate therapy. Everyone has their own way, and we don't know which is the best approach. What I typically do is increase the interval by 1 week at a time. So I'll go from 4 to 5 to 6 to 7 to 8 weeks. In my experience, I have not found many patients who at every 8 weeks can maintain that sense of control. Most of my patients, some of them can get to 5, 6 weeks, but usually the 8-week interval to me is if they can tolerate every 8 weeks twice, I'm usually able to stop their omalizumab altogether, and they do okay. Now, I'm sure there are going to be some exceptions, and there are some patients who, interestingly, will get a long-term response to a single omalizumab injection. Anecdotally, there are patients who will do well for 6 months and then need another dose. And I have very rare patients like that. So there's certainly some extremes to this.
Okay, our next question says, I missed the first 20 minutes, but did you discuss stress and anxiety with these patients?
Thank you for the question. And no, I didn't. I think we do recognize that stress is certainly perceived as a common trigger in patients with chronic urticaria. There have been a few studies that have looked at the use of anxiolytics or antidepressants in patients with chronic urticaria, but they're relatively modest. I think one thing is that we don't want to tell patients is that this is purely stress-induced, which is a lot of times what is told by other providers. That's clearly not the case, but can it have an additive effect? I believe it can in some patients. And so if you identify those patients who really have a strong anxiety trigger to their urticaria, perhaps addressing that may give you some value in terms of better management.
Okay, I think this is the last question we'll have time for. It says, as a cause for the hives, are there any studies to look at the psychological therapy being effective as another modality?
I'm not aware from a diagnostic perspective looking at addressing this from kind of a psychological approach and labeling as a disorder that you have anxiety and that is why you have hives. To my knowledge, the only form of urticaria that is purely stress induced is something called adrenergic urticaria, which is actually quite rare, and this is where stress is the only thing that drives their urticaria.
Okay, well, thank you so much today, Dr. Khan. We really appreciate what you've had to tell us, and I'd like to thank our listeners for joining us today. Please join us next month for our August webinar on August 8th at 4 p.m. Eastern. We will be talking about improving asthma care by using asthma tools. And that will be presented by Allergy and Asthma Network President and CEO, Tanya Winders, and Dr. Don Buckstein. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigation bar near the top of the page and scroll to webinars. You can also view this recording and our archived webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. For the staff at Allergy and Asthma Network, this is Sally Schessler. We're wishing you a great and a healthy day as we work to breathe better together.